Bismillahirrahmanirrahim. Never give up because great things take time. The topic of my presentation is epidemiology of SARS, which is a communicable disease and also known as severe acute respiratory syndrome. These are the learning outline of my presentation, and we discuss about background of SARS, epidemiological triad, mode of transmission, level of prevention, and surveillance system. In the end of session, participants will able to understand about SARS infection, outbreak of SARS, epidemiology, and surveillance. Background of SARS. SARS is basically a severe acute respiratory syndrome, is the first important new infectious disease of the new millennium. It is now believed that the disease is caused by a novel coronavirus, SARS-CoV. SARS was first recognized as a distinct entity in February 2003 by Dr. Carlo Urbani, an epidemiologist in Hanoi and Vietnam. Unfortunately, he himself contracted the disease and died. Since then and up to June 2003, the disease has This is the chain of transmission of different countries in which the different persons are was involved. The disease was start from the China, and then these people go to the Hong Kong, and then you can see in this diagram that the disease is spread in different countries: Hong Kong, Canada, China, Vietnam, Singapore. These are the countries which was affected at that time. SARS outbreak. The year of this outbreak was 2002 to 2004. Was an epidemic involving SARS caused by SARS-CoV and SARS-CoV-1. The outbreak was first identified in Wuhan, Guangdong, China on 16th November 2002. Over 8,000 people from 29 different countries and territories were infected and 774 died worldwide. The major part of the outbreak lasted about 8 months. Then the WHO declared on 5 July 2003. However, several cases were reported until May 2004. So the period of this outbreak is 2002 to 2004. And then in December 2019, SARS-CoV-2, a new strain of corona closely related to the one that caused SARS, was discovered in Wuhan, China. This new strain is the cause of ongoing COVID-19 epidemic. According to WHO, the disease caused by novel coronavirus SARS-CoV-2 is now officially called COVID-19. This is the family tree of the different strain of these virus. Basically, these all strains belong to a family, orthocoronaviride, and then it is divided into 4 subtypes: alpha coronavirus, beta, delta, and gamma. And then these are the strain from these genus. And SARS-CoV is related to beta coronavirus, MERS, and SARS-CoV-2. These belong to a beta coronavirus. Now we discuss epithelial cells of lung. The virus entered the host binding with the angiotensin converting enzyme. This is the animal origin of human coronavirus. The main host of all these strain is a horseshoe-shaped bat, and then these all are the intermediate host, and then it affects the human. SARS and MERS and were transmitted to human from bats by civet cat. The intermediate host for the SARS is civet cat. Civet cat. And for the SARS-CoV-2, this is the pangolins, and MERS is the intermediate host for the dromedary camels. Epidemiological triad host factor. The ages which are prone to this disease, almost all ages are susceptible for the coronavirus, equal risk in both sexes, and immunity, no role of lifelong immunity, hence proved. These are the environmental factors: temperature, humidity, food, water, sewerage, inanimate objects, and hand. How this disease is spread. The main reservoir, the natural reservoir of this disease is horseshoe bat, and the droplets from these bat are eaten by a civet cat, and the civet cats are the intermediate host for the SARS. And source of infection is nasopharyngeal secretion mainly. How this disease is transmitted. This disease is basically transmitted from infected individual when he cough or sneeze, and then from the droplets and droplet nuclei. This disease is transmitted through airborne to a susceptible individual. These are the direct mode of transmission and also indirect mode of transmission. Incubation period. The incubation period of this disease is usually 2 to 10 days. This is the pathogenesis of SARS. Virus initially affects ciliated epithelial cells of the lung, and then it activates the macrophages and T lymphocytes. The typical clinical course, whether it is improvement in symptom during the first week of infection or worsening of symptom during the second week of infection, death mostly result from the respiratory failure due to diffuse alveolar damage, and fatality rate of this disease is lesser in the young patient, and it is more in that patient which are above 65 years of age. Clinical features. Clinical features basically divided into 3 stages, and the first stage is acute one, in which fever, dry cough, body aches, headache, chill, dizziness, and sore throat. And the second stage is more complicated, because in this stage there is a shortness of breath in the patient, and if the disease is not settled, then ultimately there is development of pneumonia, DIC, and even death. These are the clinical course, progression, and laboratory features of SARS. You can see in this slide that onset is start from mild symptoms, fever, chills, myalgia, dry cough, and other symptoms. If these symptoms are settled, then the disease is not worsened. But if it is progressive, then mostly people are on the oxygen dependency. Gradual improvement is happening in week 2, or there is a deterioration in week 2, and in week 3 is the recovery week, or patient may die due to different complications. The main complication of this disease is pneumonia, pulmonary decompensation. 20 to 30% of patients require intubation and mechanical ventilation. In some patients, also seen episode of diarrhea and septicemia. What are the level of prevention? Basically, we have a 3 level of prevention: primary, secondary, and tertiary. In primary level of prevention, we control this disease with the help of health promotion, and in health promotion we educate the people about the disease and active cases, and for the active cases we isolate and quarantine that people, wear mask, uh, and habit of cleanliness is developed in the person and then comes a specific protection. There is a no role of vaccination as such uh, proven in this state, and we can uh, attain level of prevention by prompt identification of person with SARS, their movement and contact, effective isolation of the patient if they have sign and symptom, and the test become positive, appropriate protection for the healthcare worker, exit screening of international travelers, and accurate reporting and sharing information with other authorities and the government. In the second level of prevention, we early diagnose this disease. And for the early diagnosis of this disease, we take detailed history from the patient and different tests we can perform in the lab like PCR, ELISA test, chest X-ray, and virus isolation. Specific treatment. When this disease is occurring in 2003, then these medicine are used for the treatment of the people, antivirals, intravenous immunoglobulins, and corticosteroid. Prognosis. The mortality of this disease is related to the age. It is less than 1% in patients whose age is 24 years, and it is more in that for people who are above the age of 65 years. And if there is a comorbid conditions, then the prognosis is not good, like chronic hepatitis D, high initial lactate dehydrogenase concentration, high neutrophil count, diabetes mellitus, chronic kidney disease, low immune status of the patient. These all are the poor prognostic factor for this disease. When the outbreak is occurring in 2002 to 2004, then there is the establishment of proper surveillance and reporting system at that time, and CDC define the disease, give the proper case definition and laboratory criteria for this disease at that time. Now we see what is the case definition of SARS at that time. CDC define a suspected case of SARS person with onset of fever, temperature, lower respiratory tract symptom within 10 days of either travel to an area with a documented transmission of SARS or close contact with a person believed to have a SARS. This is the criteria which is given by CDC. This is the clinical definition, and the laboratory criteria is also detected at that time, in which we can see that there is a PCR test is important and ELISA for the uh, people who have the sign and symptom of disease, and the aggressive measures are taken at that time to control this disease. Quarantine of thousands of people, travel restriction to that area where the disease is epidemic, temperature check at airports. At the end, we can say that why do SARS-CoV vaccine not exist? The pharma scientific intelligence and business model must be revisited. This is an article which is published in online 16 June 2020, that why there is no as such work on the development of SARS vaccine. Development of vaccine avoided since 2003 because the market size of these vaccine was assessed to be small by the big pharma companies, and they show no interest for the development of the vaccine. If they develop the vaccine at that time, it might be helpful in this pandemic situation of COVID-19. This is the references of my presentation. MCQs. SARS-CoV belongs to which genus? Alpha
Beta
coronavirus,
Beta coronavirus.
Correct answer. The SARS outbreak was first identified in
China.
China, Singapore, Vietnam, Canada. G.
China.
8. Correct answer, China. The duration of SARS outbreak was
2002 to 2004.
2004.
C.
C.
2004.
Correct answer. The intermediate host for
V.
SARS-CoV.
Civet
B. Civet
cats.
cats.
Correct answer. Which of the following coronavirus caused thousands of deaths around the world as an emergent virus? MERS, SARS,
B.
OC40.
B.
SARS described as zoonotic virus. What does it mean? Virus confined to animal do not cause disease in human. They emerge from animals cross species
C.
barrier. C.
C.
They cause pandemic. Yes, C is
C.
correct answer. In which age group mortality rate is high from SARS?
D.
D.
Infants.
65 years.
Older
D.
above 65 years.
Previous SARS break affect how many countries are affected? 27, 29,
29.
31, 32.
20.
29.
29.
B.
29. B. The virus mainly infect epithelial cell
A.
of respiratory tract.
A.
A.
Epithelial of respiratory tract.
Correct. The SARS virus is
A.
single.
A.
This is the key of these MCQs. Thank you.
Thank you very much, Dr. Naila. Please announce the results.
Ma'am, Dr. Khansa, Dr. Mehreen, Dr. Sadia.
Okay, very good. Dr. Mehreen, you are always in the list of the winners, and I'm so happy that you are doing a lot of hard work. Khansa and Dr. Sadia, congratulations. The most important thing is about the SARS-CoV-1. Whenever we talk about SARS-CoV-1, we are looking for the similarities and differences with SARS-CoV-2. Dr. Naira has presented the good report. Naira, everyone, put your mic. Okay. Now, the similarities and differences of SARS-CoV-1 and SARS-CoV-2, that is something that we are looking for. It is a good presentation, but we want to know more about the human coronaviruses before we go to SARS-CoV-1. We all know that there are 6 species of human coronavirus that are known, and one of those species, it has 2 subgroups, and so we can say that there are 7 different type of coronaviruses that are known to infect humans. However, there are many other coronaviruses that are mostly in the animal population. So the reservoir is very important whenever we talk about coronavirus. We know that SARS-CoV-1 is a viral respiratory disease that is associated with coronavirus, and it has shown to cause epidemic back in 2003. After that, it quickly spread to many countries, and the SARS was identified at that time, and there were certain measures to control it, like use of mask, hand hygiene, and social distancing. It has been a good account why the vaccination was not developed against SARS-CoV-1. If it has been developed at that time, it would be beneficial when the pandemic of SARS-CoV-2 has occurred. And the damage that has been caused by SARS-CoV-2, it would not be as much as we have witnessed now, because the vaccination would be there for SARS-CoV-1, and it can be modified and can be tested and can cause better response in humans. However, the SARS-CoV-1, it was not being identified in young children, just like SARS-CoV-2. We know that SARS-CoV-1 is more dangerous in people who have comorbidities, who have old age. And yesterday, Dr. Sadia Rafiq has explained the different dimensions of SARS-CoV-2 virus infection that is called COVID-19 disease. Similarly, the SARS-CoV-1, when it was identified, it is more in the adults aged 25 to 70 years. So my important question here is that why this disease, both of those diseases, sorry, SARS-CoV-1 and SARS-CoV-2 are more affecting the adults rather than the children. As I have told you that there are only few suspected cases of SARS-CoV-1 that have been reported among children under 15 years. And yesterday, Dr. Sadia has told us that this is the disease that is very less in children. So my question is why that is so? Why it is more in adults rather than in children? Anybody from the class, please? Dr. Naila? Dr. Sadia?
Yes, ma'am, because as elderly patients have comorbidities along with the low immunity and the risk factors like if they are already smokers and respiratory problems, asthmatic, then they
Okay, Dr. Sadia, the actually pathogenesis that is behind it, that SARS-CoV virus that attaches with angiotensin receptors. And it has been seen that those receptors, they are not very mature in children. However, these receptors, they are present in the respiratory tract of adults. And the comorbidity factors, yes, it comes after that, because once the virus is attached with the receptor, then there are the chances of causing pathogenesis, and it would lead to the viral entry into the cell, replication, making copies of the virus, producing immune response, cytokine storm. There are certain type of innate immunity mechanisms as well as adaptive immunity mechanisms that are involved in it, both including the humoral response of B cells as well as the memory T cells and T cell mediated immunity. But before that, the importance of angiotensin receptor has been documented that SARS-CoV virus needs angiotensin receptor for attachment. So it is the angiotensin receptor that are less in children. This has been reported in research. The second important thing is, as you have said, that smoking. Initially, the role of smoking was reported in research that smoking was not found to be associated with the severity of SARS-CoV virus. However, later on, there is a lot of evidence now that smoking increased the risk of cytokine storm of all the symptoms and signs of SARS-CoV virus and increased the risk of pneumonia mortality. So now we know that smoking is one of the risk factors that is causing more deaths due to SARS-CoV virus. As far as COVID-19 disease is concerned, we know that a lot of research has been done in all the parts of the world, and it has been seen that certain comorbidities like obesity. Second important thing is diabetes, hypertension, dyslipidemias, chronic diseases like chronic obstructive pulmonary disease, chronic liver disease, chronic kidney disease. They are associated more with the morbidity and mortality of COVID-19 disease. And similar is the case with SARS-CoV-1. The comorbidities increased the risk of the mortality through SARS-CoV-1 too. The another important aspect of all this discussion is the role of gender. May I ask what is the role of gender in having the signs and symptoms due to the disease caused by SARS-CoV-1 as well as SARS-CoV-2? Dr. Mehreen.
Ma'am, the prognosis is worse in males than females.
Thank you very much, Mehreen. We have seen that the disease that has been caused by SARS-CoV virus, it is affecting more males rather than the females. And the females, they are seen to have more resilience, and they are less affected by the severe disease as compared to males. Result, and we can even guess that the result would be that there is a less mortality in females as compared to males. Moreover, it has been found in research that the antibody titers that have been documented after SARS-CoV-2 virus infection, it has been found that females have antibody titers that persisted for a longer period of time rather than males. Females, even at mild level of the disease and the moderate level of the disease, they are able to produce much more antibodies rather than their male counterparts. Similarly, we have seen when we are talking about the similarities of SARS-CoV-1 and SARS-CoV-2 virus infection and their disease patterns, we always talk about the case fatality rate. May I ask Dr. Hansa, what is case fatality rate? Dr. Hansa, please. Okay. Dr. Hansa, please unmute your mic. Anybody from the class who can tell me what is case fatality rate due to
As the
SARS-CoV?
case fatality rate, the denominator is the confirmed cases by lab. And the case fatality rate, so in denominator is the deaths from the confirmed cases.
Okay. Deaths due to certain disease or among the cases that have been confirmed in the laboratory divided by all the cases that have been confirmed for that disease through the laboratory test. Very right, Dr. Sadia. Thank you very much. So the case fatality rate, as we know that we have seen that the SARS-CoV-1 and SARS-CoV-2 have a comparable case fatality rates. SARS-CoV-1 was not spread to many countries. It was more quickly curtailed in certain countries. However, in SARS-CoV-2 virus infection, we have seen in COVID-19 disease that almost all the countries of the world have been affected. There are more than 200 countries that have reported the SARS-CoV-2 virus in their population. So the case fatality rate, however, in both of these diseases, that remained near 3%, and that was comparable. Another important difference between SARS-CoV-1 and SARS-CoV-2 was about the spread of the disease, about the transmission, and about the variation or mutations in genetic makeup of the virus. As we have talked about many similarities, and there are also many differences, we have seen that SARS-CoV-1 virus, again, the RNA virus, but the mutations have not been reported as much as with SARS-CoV-2. SARS-CoV-2, again, RNA virus, and lots of mutations have been reported. The recent mutation that has been reported, it has increased the affiliation of the virus with the receptor. It says that this binding of the virus with the receptor increased the amount of the time that a virus remains inside the body. And so the pathogenesis has been increased. And that again, this affinity has shown to increase the transmission of the virus. It has not been proved that whether all these affinity binding and more receptor being affected by the virus increased the virulence of the virus and pathogenicity of the virus. We don't have any evidence about it yet. However, according to the hypothesis, it suggested that whenever there is a more binding of the virus with the receptor, there would be more pathogenicity, there would be more period of the virus to cause destruction in that human, and also as it is more affinity with the cells, there would be more chances of transmission for a longer period of time. So it shows that the severity of the disease is indirectly related with the presence of the virus for a longer time in any human. However, we are still looking forward to certain research that would help us in finding all these things about the virus. The last thing is about the vaccination. As we know that SARS-CoV-1 vaccination was not there. However, the major difference in SARS-CoV-2 that there are many vaccines that have been used in population, like Pfizer, Moderna, AstraZeneca, and CanSino Bio, Sinopharm, and Sputnik of Russia. So in SARS-CoV-2 virus, we have seen that vaccines that have been developed, it was in the shortest possible time in the history of mankind that the vaccines have been developed against a very uh, virulent virus or a disease that has a spread over 200 countries in the whole globe, and that vaccines would lead to the herd immunity and stopping of that pandemic that is keep on going in the form of the first wave, second wave, and we are at a position where the vaccination has been developed. It has been started in USA, UK, Europe, UAE, Israel, and many other countries. And soon in Pakistan, we would be able to have that vaccine, especially in our community, and that would lead to the herd immunity, and this pandemic would end. Till that day, we are little spectacle about the mutations of the RNA virus, because the RNA virus, they are known to have these mutations, and the RNA virus, they are notorious of having mutations. So what would be the effect of these mutations on vaccination? It is a question that we are still pondering upon. As far as Pfizer is concerned, they have given a vaccine at a very large number in USA, and they are having this uh, research going on that the mutation has not affected their vaccination program. And the Pfizer that has reported to have the efficacy above 95%. Efficacy above 95% is a very good efficacy, actually. So they are able to document it that these mutations are still responding very well to the Pfizer vaccine. Similarly, we know that Moderna, again, it has an efficacy above 92%, again a very good efficacy. So all these things would lead to the mutations and follow up after vaccination, and the corona registry system that would allow us to know about the post-COVID complications, as well as different type of the mutations and how the vaccines are responding against it more accurately with passage of time. So the most important lesson that I want to give you in the end was, number first, vaccination is the only viable option to end this pandemic. Number second, we are very hopeful that all those vaccines that have been developed so far, they would be able to cater for all those mutations that have been reported till now. Number third, all those preventive measures, they are still very helpful, even when a person is vaccinated, or even when the vaccination program is running successfully in many parts of the world. Still we need to have preventive measures, including mask, hand hygiene, and social distancing. All SARS-CoV virus story help us to understand better about the health, about the preventive measures, about the epidemiology, and how the humans are resilient against different catastrophic events. Thank you very much. We stop here. If you have any question, you are most welcome to ask. Okay, Allah Hafiz.
Thank you, ma'am. Allah Hafiz.